Salam alaikum. Hello, this is OFP, likely to discuss about the psychiatry. Start with this stress disorder. I mean, lot of stress. Everyone is in stress. Stress is everywhere, and the duration of stress should be more than 3 days, less than 1 month. This is the high-level word. You have to remember that more than 3 days and three or more than 3 days and less than 1 month. Suppose a 42-year-old woman comes to you, is feeling nauseous and down for the past 2 weeks. And when you find this stress disorder question, to you have to rule out another differential panic disorder. Like in this stem, what I am going to discuss that this patient is she has poor concentration, she has palpitation, shortness of breath, sweating, but the time duration, look at the time duration. Sh- she's feeling nauseous and down for past 2 weeks, and there is underlying background here that she has been mugged 3 weeks ago while walking home from work. While walking home from work, she is crying. She says that I can't snap out it. I'm in a daze. She has When she visits to the psychiatrist, she says that she is having minimal eye contact, looks down on the floor, wrings her hand repeatedly. This thing actually distracts you. So, in acute stress disorder, the underlying differential would be the panic disorder, underlying differential would be PTSD, there may be underlying things about the generalized anxiety disorder. So, how you will rule out? First of all, think about the time duration. If it is more than 3 days, less than 1 month, the diagnosis is done, acute stress disorder. But if it is more than 1 month and meet the criteria, uh, then you have to think about PTSD also in post-traumatic distress stress disorder. And see if this type of symptom persists more than 1 month, then you have to think about PTSD also. So there may be exposure to actual or threatened trauma. In this stem there is actual trauma happened. So what are the clinical feature? Avoidance of internal memories or external reminders. There may be there may be intrusion nightmare flashbacks. There may be dissociation amnesia for event. There may be derealization. Am I me? There may be arousal, insomnia, hypervigilance, and startle, and there may be negative mood. These are the features, these are the things you will find in acute stress and disorder. So the word is acute. So A for acute, A for avoidance, A for arousal, A for avoidance, A for arousal. Avoidance of internal memories and external reminders, and arousal. The There may be trauma focused. This is another important word in acute distress disorder. You have to when you are discussing about the patient, talk about the physical and emotional response to the trauma and brief cognitive behavioral therapy. This is the first line you have to think about. Consider medication for insomnia if as he is having difficulty on sleeping. So think about giving something for her sleep. And intense anxiety, monitor for PTSD. She has to monitor for PTSD. That is all about acute stress disorder. Next question, like HIV associated neurocognitive disorder. In HIV associated neurocognitive disorder, like suppose a 58-year-old man 58-year-old man has some sort of personality problem, like increasingly bizarre behavior for the last several months, increasingly bizarre behavior for the last several months. She and if you just asking about her memory, he has HIV. He has diagnosed case of HIV 25 years ago, and he is on antiretroviral therapy. And when I am going to look for his mentation, three item recalled is normal, but unable to count backwards from 100 by 7, or to spell word backward to spell word backward. When he asked to explain the meaning, do not count your chickens before they hatch, he laughs and says that I guess you just should not count too many chickens, but that means he is not understanding what I am trying to say, what I am trying to mean. I have done MRI, and there is reveals ventricular enlargement and increased intensity in the white matter diffusely. This scenario, as there is ventricular enlargement, increased intensity in the white matter, think about another differential like PML, because AIDS patient or immunosuppressive patient has propensity of developing such a sort of disorder. It may be due to HIV associated neurocognitive disorder. In HIV associated so my diagnosis is HIV associated neurocognitive disorder. How I have found this: long-standing HIV, age more than 50, and there is impaired memory and attention concentration. There is personality problem. In this patient, there is no motor symptoms like ataxia or slow movement. Uh, he has neurocognitive impairment, mild neurocognitive disorder, and there is HIV associated dementia. Diagnosis is clinical presentation, and neuropsychological testing should be done to diagnose. mm, Testing should be done to diagnose HIV associated neurocognitive disorder. HIV associated neurocognitive disorder. Why it is not PML? In progressive multifocal leukoencephalopathy, usually caused by the reactivation of the JC virus, uses symptom is psychoacute. Altered mental status is common, but manifestation generally reflect on the cortical involvement. Assalamu alaikum, back again. And HIV associated neurocognitive disorder, there is a long standing HIV disease and clinical presentation. Diagnosis is clinical presentation and neuropsychological testing. SSRI. Sometimes, if you give SSRI, there may be early adverse effects like nausea, diarrhea, headache, increased anxiety, and insomnia increases. And that very particular case, what you have to do is to decrease the dose of SSRI, temporary reduction of the dose. Why we are reducing the dose? To increase the goal of improving tolerability, and that is the concept I am going to discuss now. That is the concept in here. So when you give SSRI, if the patient's tolerability is poor, like there is increasing symptom, then you should reduce the SSRI dose. And some patient, there is uh, if the patient has difficulty in falling asleep, that means he has some sort of night owl tendency to fall asleep and wake at unconventionally at late time naturally. mm, Wake at unconventionally late times, that he is fatigue and sleep symptoms. He has some sort of fatigue and sleep symptoms, like a patient, 29-year-old nurse having difficulty having sleeping difficulty since he received promotion from several weeks ago. Mm, Initially the patient's shift was but now he, as his position changed, now his working shift is 7 a.m. to 4 p.m. Previously it was 4 to 12 am for many years, and has no and had no sleep difficulties. However, currently he fall asleep until 2 am on a typical night. Cannot fall asleep 2 am on typical night. The patient awakens by alarm at 6 a.m. to get ready for work and feel exhausted and pronounced sleepiness during meetings. She gets tired all the time, but in the off days, she sleeps from 2 a.m. and she sleeps from 2 a.m. until 11 a.m. and does not feel tired. That means his previous sleep disorder, his previous sleeps, he cannot unable to adapt with his new sleep cycle theme. That's why this problem arises, that the patient's sleep patterns are consistent with delayed sleep wake phase disorder, a circadian rhythm disorder characterized by consistent, unconventionally late sleep and wake times. So that is the problem in here. So, so it will take time. It will take time to adjust. This type of disorder is typically unmasked when the patients are required to conform a schedule with early wake times, leading to bothersome symptoms such as daytime drowsiness, malaise, and gastrointestinal problems. Next is lithium toxicity. If the patient has if the patient is if the patient is getting lithium for bipolar disorder, and if there is neurological symptoms like altered mental state, seizure, and fasciculations, and tremor, and some GI manifestation, you should do you should see the lithium level. If the serum lithium level is more than 2.5 milliequivalent, uh, then hemodialysis should be done. If patient is not having symptom but the lithium level is more than 4 and creatinine is more than 2, then you should do dialysis regardless of the symptom. Then the generalized anxiety disorder, GAD, that and this is excessive uncontrollable worry of multiple issue, excessive uncontrollable worry of multiple issues, more than three of the following symptoms and more than one in children: restlessness, mm, and feeling on the edge of the feeling on edge, fatigue, difficulty concentrating, irritable muscle tension, sleep disturbance, chronic fluctuating chronic fluctuating course, and academic and occupational dysfunction, cognitive behavior therapy, SSRI, and these sometimes you can give buspirone. An associated feature: increased risk of health care utilization, increased risk of high healthcare utilization, cardiovascular events, comorbid depression may be seen. And the next is adjustment disorder. Adjustment disorder is involves the emotional and behavioral symptoms like anxiety, depression, and disturbance of conduct developing within 3 months of an identifiable stressor. More than 3 months, developing within 3 months, but lasting no longer than less than lasting no longer than less than 6 months, lasting no longer than 6 months once the stressor ceases. Like 18-year-old woman, difficulty sleeping and fatigue. The patient started attending college 2 months ago and lives alone in an apartment. For the past month, she is increasingly anxious at night and thinks that someone is going to break into her home, and despite living on the 8th floor in a safe neighborhood, the patient struggles to stay awake during class and worried uh, that her lack of sleep is beginning to affect her grades. She feels tensed when walking alone on campus and spends time with friends only during the day. These things actually means she has some sort of adjustment problem, but in this question there is another thing that try to distract you, that this patient makes sure to check from the front and the balcony doors and are secure every night and locks her bedroom before going to bed. This is a distractor. You may think about OCD, but this is not a case of OCD. If there is specific phobia that, like he is unable to enter into the elevator, he is avoiding bridge, he has some sort of height phobia, and he has a previous history of something happened in his family about height related, then these things about this is the thing about the specific phobia. Mark anxiety about a specific object or situation, like this patient, 28-year-old man, every time he is in the elevator, his heart pounds, and he cannot catch his breath. He is having a panic attack on daily basis. So it is specific phobia for more than 6 months. This is high yield specific phobia for more than 6 months. Com Common in 10% population. CBT, cognitive behavior therapy with exposure therapy. This is the first line. Exposure therapy. Exposure therapy. Short-term benzodiazepine, limited role. It may help if the therapist is unable or insufficient time. Short-term benzodiazepine can be given. Now, panic disorder. In panic disorder, recurrent and unexpected panic attack more of the following. Recurrent or unexpected panic attack or of the following. If the patient is panicking, like there is chest pain, palpitation, shortness of breath, choking, trembling, uh, abdominal pain, dizziness, derealization, depersonalization, fear of losing control, fear of dying, fear of worry about additional attacks and avoidance behavior. This is panic. Mm, First line is SSRI or cognitive behavior therapy. If the patient has acute problem like this patient, 22-year-old woman, comes to the ED with onset of nausea and diarrhea. He has abdominal distress resolved, but she remains agitated. There is something really wrong with me. Over the past 2 months, the patient has four similar episodes which he experienced sudden sinking feeling in her stomach accompanied by nausea, sweating, rapid heart rate, and on occasional these symptoms were accompanied by uh, she has become increasingly forceful and leaving her home and tearfully reports, I'm going to lose my job. He is in very distressed condition. So it is acute problem. Give some lorazepam. That means give some benzos. Benzos will work here. Again, acute stress disorder. I have already discussed you about acute stress disorder. Now, post-traumatic stress disorder. In post-traumatic stress disorder, in post-traumatic stress disorder, the treatment is trauma-focused. Trauma in post-traumatic stress disorder treatment is trauma-focused and cognitive behavior therapy. Like a 61-year-old man having a heart attack 2 months ago. Now he has some sort of fear. He has some sort of fear of losing, passing out. Uh, so some sort of fear of passing out. This is PTSD, trauma focused cognitive behavior therapy, and antidepressant can work here. Antidepressant can work here. If the patient having chronic insomnia, cognitive behavior therapy for insomnia is the first line treatment for chronic insomnia patient, and it can successfully resolve chronic insomnia without medication. All you have to do is to mm, make improve sleep behavior, recommend keeping a diary of sleep for a week. Stop chronic insomnia patient establishment an optimal and consistent wake sleep time across weekdays or weekends. Avoiding sleeping late, first of all, limiting time spent in bed awake. Instead of watching television, physically leave the bed if they are awake in bed for more than 20 minutes. Improving sleep hygiene by moderating caffeine intake, limiting alcohol use, addressing sleep anxiety. Uh, in major depressive disorder, pediatric depression may comes with irritability, annoyance, argumenting behavior, irritability, annoyance, and irritability, uh, annoyance, and argumenting behavior rather than depressed mood. Identification of the appropriate treatment is important to decrease the distress and limit the impairment in social, emotional, and academic uh, development. If adjustment disorder, adjustment disorder, like a 22-year-old woman comes to you, he hasn't got chance in the top university, but he has got admitted, but he received multiple acceptance from other programs, but he's thinking that my life is ruined, I am a failure, I'm a total loser. So see, he has some problem of adjusting. It is mood and behavioral symptom onset within 3 month onset. Within 3 months of identifiable stress or marked distress and/or functional impairment does not meet the criteria of another DSM-5 disorder. Normal stress response, not excessive, impair, no significant impairment, and acute stress disorder and major depressive disorder. Major depressive disorder, acute stress disorder, normal stress response. All three are differentials of major. All three are differentials of adjustment disorder. Psychotherapy is the treatment of the choice. Adjunctive pharmacotherapy, short-term, reserved for rapid relief of impairment symptoms like sleep aid and anxiolytic. GAD in children, um, restless and feeling on the edge and fatigue, and these sort of more than one symptom, excessive uncontrollable worry for more than 6 months, and mm, more than one symptom. Associated feature is perfectionism. Generalized anxiety disorder in children, differentials are adjustment disorder, response to identifiable OCD, separation anxiety disorder, and social anxiety disorder. These are the differential: adjustment disorder, obsessive compulsive disorder, separation anxiety disorder, social anxiety disorder. Treatment of bipolar disorder during pregnancy in acute mania, typical antipsychotic haloperidol and atypical risperidone, olanzapine. Olanzapine causes obesity, risperidone can cause hyperprolactinemia. In acute depression, lamotrigine, quetiapine, atypical antipsychotic and SSRI, except paroxetine. Paroxetine can cause cardiac effects, so it should not be given. It has some sort of teratogenic effect, and valproate, carbamazepine, oxcarbazepine, neural tip defect, neurodevelopmental disorder. For maintenance, lamotrigine, acute depression, lamotrigine. So, bipolar disorder during pregnancy, in acute depression, lamotrigine, maintenance or relapse prevent. Lamotrigine, atypical antipsychotic, quetiapine, and risperidone can be given. Lithium, small increase absolute risk of fetal cardiac defect, small and increase risk of fetal cardiac defect. This is this is an ongoing process. This is the first part of my psychiatry discussion. Hope you enjoyed.